Chapter 4 Metal Ion Exposure After Scoliosis Fusion. Why talk about metal ions? Every year in the United States alone, surgeons perform close to 500,000 spinal fusions, and a significant slice of those operations are done to correct adolescent idiopathic scoliosis, AIS. Although rigid instrumentation can straighten a curved spine impressively in the operating room, the metals that make this possible do not remain chemically inert forever. Under physiologic conditions of salt, motion, and microcurrents, even high-grade stainless steel and titanium constructs can shed microscopic particles and free ions into the surrounding tissues and ultimately into the bloodstream. Patients, parents, and clinicians therefore need to understand not just how well the rods hold a curve, but how the ions they release may affect bone healing, systemic health, and the long-term success of the fusion. How do ions escape? Two intertwined processes, fretting wear, the mechanical abrasion of metal surfaces, and electrochemical corrosion, the gradual oxidation reduction of the alloy, drive ion release. Laboratory and retrieval studies show that the rod-screw junction is especially vulnerable because cyclic loading and small micromotions continuously disrupt the protective oxide layer. Clinicians used to assume that corrosion was mainly a midlife wear-in problem, but a 2015 prospective pilot study of instrumented AIS cases demonstrated a sharp intraoperative spike in titanium, niobium, and aluminum levels, confirming a putting in phenomenon that begins the moment hardware is locked down. What do retrieval studies show? One of the most cited analyses examined stainless steel constructs removed from 11 scoliosis patients after solid fusion. Researchers graded each rod hook or rod crosslink junction for visible corrosion and found damage at 66% of junctions, often deep enough to produce severe metal loss. Their sober recommendation? Once bony union is achieved, consider routine removal to stop continued ion leakage. As the lead author noted, corrosion takes place at many of the rod junctions in long-term implantation. Early ion kinetics, faster than expected. In the Cundy pilot study, 2 pediatric patients had serum titanium and niobium levels drawn at induction, post-op day 1, day 7, and day 28. Titanium rose more than tenfold within 24 hours and remained significantly elevated a month later. Local wound irrigation fluid and even the cleaned cell-saver blood contained higher metal concentrations than simultaneous serum samples, proving that ions are washed directly back into the patient. The authors advised copious irrigation before closure and filtering of cell-saver blood to limit the initial dose. Systemic burden over time. A 2024 meta-analysis pooling more than 1,200 fusion patients confirmed that chromium, titanium, cobalt, aluminum, and nickel levels stay chronically elevated after surgery, with a pooled mean difference of 0.56 micrograms per liter for whole blood titanium compared with preoperative controls. Heterogeneity was high, but every study reviewed showed upward drift, and the trend correlated loosely with the number of fuse levels and time since implantation. Cell-level consequences. Once released, nanoscale particles and free metal ions readily enter macrophages, migrate via lymphatics, and can lodge in marrow, liver, spleen, or kidney. In vitro work summarized by Sansone and colleagues reveals that ions such as cobalt and vanadium generate reactive oxygen species, impair DNA repair, and trigger apoptosis in osteoblasts. Particulate debris promotes a foreign body granulation tissue response that results in progressive local osteolysis, threatening fixation of the hardware, the review concludes. Clinical ripple effects, metallosis, and pseudarthrosis. Corrosion is not merely cosmetic discoloration hidden under muscle. Case series link elevated local ion loads with delayed union, implant loosening, and painful metallosis, a gray-black inflammatory mass that can compress neural elements years after an apparently successful fusion. TreatingScoliosis.com warns patients that hardware can rust inside the body, leading to pain, swelling, and loose implants. A plain language summary of what surgeons see in revision rooms worldwide. Numbers worth remembering. 66% of junctions corroded in long-term stainless steel constructs. 10 times median rise in serum titanium within 24 hours of surgery. 0.56 per liter pooled mean excess titanium in post-fusion blood. Up to 20% estimated revision rate for implant failure related to corrosion or pseudarthrosis in long-term AIS cohorts, according to registry data cited by several reviews. These figures emphasize that ion release is neither rare nor trivial. Mitigation strategies. While modern titanium alloys corrode less than stainless steel, they are not immune. Surface engineering, anodization, titanium nitride and diamond-like carbon coatings, and ceramic sleeves shows promise in laboratory fatigue corrosion tests. The Number Analytics Technical Review notes that hard coatings lowered cobalt ion release by 90% in hip simulator studies and cut fretting volume loss in spinal rods by orders of magnitude. Yet clinical evidence in spine remains thin, and design complexity still creates crevices where galvanic couples can flourish. For existing patients, surveillance strategies include baseline and periodic serum metal panels in symptomatic or high-risk cases, advanced imaging, MRI with metal artifact reduction when late pain or neurologic change appears. Shared decision-making about implant removal once fusion is radiographically solid, balancing surgical risk against continued ion exposure. Implications for the scoliosis community: whole-body, brain-based paradigms of scoliosis care, which I advocate elsewhere in this book, stress minimal biologic disruption. The evidence above reinforces that goal. Fusion hardware alters spine mechanics, but also creates a new, lifelong variable, metal ion load, that may interact with genetics, hormones, and immune balance in unpredictable ways. Families weighing operative options deserve transparent data on both curve control and ion biology. Future directions. Better alloys. Computational alloy design is producing beta titanium blends with higher corrosion thresholds and lower elastic modulus, potentially reducing both ion output and stress shielding. Smart coatings. Ionic pump and graphene-based layers under investigation promise self-healing oxide films when scratches occur. Long-term registries. Linking ion assays with patient-reported outcomes will clarify dose-response curves for systemic effects such as fatigue, rashes, or endocrine changes. Personalized risk profiling. Integrating metal sensitivity genetics, for example HLA-DRB1 variants, with curve severity may inform who benefits, or suffers most, from permanent implants. Key takeaways. Corrosion and metal ion release start intraoperatively and persist for decades. 2/3 of rod junctions in retrieved scoliosis constructs show visible damage. Serum titanium and other ions can rise tenfold within 24 hours and stay elevated. Laboratory evidence links these ions to oxidative stress, osteolysis, and systemic toxicity. Emerging materials and removal strategies can mitigate but not yet eliminate the risk. As we refine genetic, metabolic, and reflex-based non-fusion treatments, understanding the cost of permanent hardware helps families make fully informed decisions. Metals may straighten backs, but the ions they shed echo far beyond the operating room.